Well, the title says a lot. Let me get this pointer right. And I know in pharmacy school, when I went to pharmacy school 30 years ago, we didn't talk about testosterone for women at all. And there was even, I'd like to introduce my wife, Janet. She's also a pharmacist and a lot smarter than me and obviously a lot better looking. So if you have questions, ask her. Anyway, they didn't teach us anything about testosterone for women in pharmacy school. And 3 years ago, when we first started talking about hormones, when we would go into they wouldn't recognize that we're going to get into that a little bit today. And I don't have a lot of scientific reference study. I want you guys to think out of the box today. Use our education that we got to think about there's some simple principles that we might not learn in school, but that is basically we learn in anatomy physiology 101. So disclosure, I do own a compounding pharmacy and compounded products are not FDA approved. So I wanted to go into the biosynthesis of testosterone. First of all, just a little background that testosterone is mostly made in the testes for men, of course, and then the ovaries for women. So if women have oophorectomy or they go into menopause, their ovaries quit working, their testosterone levels will be lower. Using this slide, I like using this. I'm trying to get used to this pointer. And the pointer is mostly just for me, not for anybody else, actually. But all steroid-producing cells use cholesterol as a precursor for hormone synthesis. Why is that important? Because when we give cholesterol-lowering medications like statins, it will decrease testosterone production. So these are things I want you to be looking for when patients are on statins and they have symptoms of men today, but be thinking about men too for these things, because typically it's men that get into their 50s and they have these low testosterone symptoms, and including high cholesterol, because testosterone does help lower cholesterol. And the first thing we do is we put them on a statin, and then their symptoms might get worse. So when do testosterone levels peak? For the interactive portion of the class here, when do testosterone levels peak for men and women? Okay, in the morning, that's right. What about in our life stage? What age in our life stage? What year? How old? Louder? Teens, yeah. Usually about 19 for women, for men, and for women. Our testosterone levels peak. So, but for women, it can be a little bit different. It can be, their testosterone levels are highest in women when they are pregnant. Definitely when they're pregnant. When women become pregnant, their hormone levels go off the chart. Now, why do I say that? Because when we think about postpartum and postpartum depression, should be surprised that women get postpartum depression. I get it. There's a lot of other things involved, but also immediately their hormones go down. So let's be thinking about that also. So this is a very, very important slide. What if we had a drug that decreased depression, increased bone density, decreased visceral fat, increased lean body mass, decreased cholesterol, decreased insulin resistance, decreased blood pressure, and increased libido? What if we had a drug like that? Guess what? We do. It's called testosterone. Testosterone does all of those things. Maintain normal libido and response, increasing bone mineral density. I'm going to focus today on bone mineral density and depression. These other things just absolutely come into play and they come into the discussion, but I'm going to focus on those two things today. Maintain lean body mass, strength, and stamina. Improve mood, and structure integrity of the brain. Cardiovascular benefits. Maintain skin and health. Cardiovascular benefits. So what about testosterone causing heart attacks? There's a black box warning for testosterone causing heart attack, right? For men, right? So, and if you want a reference to that study, I've got a great YouTube video. I interviewed an expert on that subject of how testosterone does not cause cardiovascular accidents. And he's referenced it. He has all the studies. But let's just think rational about it. If just association does not prove causation, right? if testosterone caused heart attacks, when would men have heart attacks? Somebody mentioned when our testosterone levels peaked. Okay, so let's just think about that. I get it, it's not that simple. That's the point, is if testosterone, if high testosterone caused heart attacks, men in their teens would be having heart attacks. Vaginal atrophy, there is no better drug for atrophy of anything in the body than testosterone. Bone, vagina, skin. Testosterone is an anabolic hormone. It's why athletes abuse it, because it makes muscle stronger, it makes bone stronger, it makes a lot of things stronger. So there is not a better drug for vaginal atrophy. In pharmacy school, traditionally we learn, and for FDA approved products, we learn that estrogen for vaginal atrophy, and it does work, definitely. Testosterone, even better. And testosterone does convert into estradiol through aromatase. So that's another benefit of testosterone when you use it vaginally. And yes, women do have testosterone. I got to tell you a quick story. As you can imagine, Janet and I speak about hormones all the time at our house. And our kids, we have two wonderful grown boys, 21 and 23 years old, super proud of them. And of course, they heard hormones from the time they were little. They heard about hormones. My son, oldest son, he got kicked out of science class because he argued with the science teacher about women having testosterone. And she said, no, they don't. And he's like, well, yes, they do. It's just a different level than men. Anyway, we had to have a conversation with the science teacher to tell them that, yes, women do have testosterone. So, so how do we monitor and test for testosterone? I'm trying to use this pointer here. So what about total versus free testosterone? We know this about a lot of different drugs or a lot of different hormones in the blood, whether it be thyroid or whether it be testosterone. There's proteins that are bound that won't really, if they're bound to a protein, then they won't work at the receptor site. Sex hormone binding globulin is a big one for testosterone. That's why it's important to have a total level and a free level, so you can really see what's going on, because only free testosterone, and most of it's about only 10% free, only free testosterone will bind the receptor site. So, but again, one thing we're going to get into is normal versus optimal, and we use labs as a tool to go along with symptoms and history. Labs are not black and white, and I think that goes with anything, whether it be cholesterol, whether it be a sodium level. Labs are not black and white. We need to look at it, the whole picture. So don't get too worked up on the reference ranges as far as nanograms per deciliter or picograms per milliliter. Just use a good lab and trust the lab's reference range, and realize that what's normal is not always optimal. That's what's most important. And test a free level. So it's important what labs to order and how to interpret those labs. So and then look at what's normal. When you look at levels, progesterone is really is a key on this one. When you look at a progesterone level, look at a progesterone level for a lab. Although testosterone is the same thing, they'll say normal for a postmenopausal woman, progesterone level is like really low. It's like, well, of course it is. They're postmenopausal, but now she's having all these symptoms. So we don't want her to be normal. We want her to be like she was before menopause. So you can't just look at normal levels. You have to know how to interpret those levels. And some labs, they will even do it even worse off. They'll say, well, normal for a 70-year-old is different than normal for a 40-year-old. So they'll change their reference range. Well, this guy's 70. This was normal for 70-year-old. Well, a lot of 70-year-olds are sick. Do we want to be normal when we're 70, or do we want to be optimal when we're 70? I mean, those are key things, normal versus optimal. And many times we don't have baseline levels. So if you look at healthy men, which we don't typically look at healthy men because they're not coming in to see us because they're not sick. So normal levels are for normal people that are accessing healthcare, right? But if you look at normal levels for healthy men in their 30s, sometimes their level is like 1200. And I will tell you, I'm guilty of that. When I was 39 years old, my level was 1250. A normal level is 300 to 800. So what would a doctor tell me when my level was 1250 when I was 39 years old and I was not taking testosterone? That I'm going to have a heart attack, that I need to give blood? I mean, what would they tell me? I mean, seriously, let's think about these things. We need to know what baseline levels are and think about that. So if somebody comes in and they have low testosterone symptoms and their level is, on the middle range of normal, that might be low for them. Just think about that. So different ways that we can dose testosterone and monitoring. So here's check a baseline level, and then 8 weeks later, and then probably annually. But it's so important to know how they're using testosterone and the timing of the lab draw versus the dosing. So topical, for instance, let's get back to women. Women, I really like vaginal application because you get systemic effects. It's a mucous membrane, great blood flow, thin skin, great absorption, bypasses first pass. You get great systemic effect, but also you get local effect. Remember the vaginal atrophy and testosterone? There's not a better drug for vaginal atrophy than testosterone. If they use it in the morning and then you check their level an hour later, their level might even be above normal and it might look high. Well, of course, they just put it on. If you don't like that, then wait 12 hours later and it will be going back down to baseline. Wait 24 hours later, and usually with topical, it will be back down to baseline. On the contrary, they haven't used it in 24 hours. They didn't use their dose that morning. They were going to get tested that morning. Well, Shawn, I don't know what happened. This patient's leveled back down to baseline. I don't think this cream is working for her. And we'll ask the question. Jan and I get this every day. We'll ask the questions like, when did she last use it? Well, she hasn't used it in 24 hours. Well, that's perfect. She's back down to baseline. So so don't double her dose. You got to know how to interpret those labs. The nice thing about topical is our skin is created beautifully to prevent things from being absorbed too fast. And usually with vaginal application, I'll have them apply to the inner thigh and the vaginal area. And especially with the inner thigh, mucous membranes definitely absorb a lot faster. But with the thigh area, it will absorb a lot slower. And testosterone actually has a short half-life. Testosterone has a half-life like 3 to 4 hours. So the skin works as a beautiful way to not let it peak too high, yet deliver it throughout the whole day. So skin is a beautiful way to deliver testosterone. Sublingual, not as much. It's an option, but the problem with sublingual is it's absorbed immediately, pretty much. Testosterone does not taste great. It's a hormone. It's a free base hormone. It's bitter, and it's got a short half-life. So if they use it in the morning, it's going to be worn off by the afternoon. So that's why if you look at some of the commercially available stuff available for men for testosterone and it's used sublingually, it's TID dosing. Injection, here's the problem with injection. Injections, you get peaks and valleys with any kind of injection. Like I said, our skin is developed wonderfully to prevent things from being absorbed too fast. Literally poisons. It doesn't know whether testosterone is a poison or not. So when you bypass that mechanism by giving an injection, it is going to give an immediate peak. Now, some people argue, it's like, well, I don't do injections every week. I have them do it twice a week. I'm like, great. I mean, good for you. But have you ever checked their level right after injection? And I talked to an endocrinologist one time about that. And she said, well, no, that'd be ridiculous. It'd be super high. Exactly. That's my point, is that injections create peaks. Now, what's the problem with that? Is that after an injection, you get too high of testosterone levels that can convert to estradiol. Not usually a problem in women, but it can definitely be a problem in men. So injections have peaks and valleys. And if you're doing it twice a week, it releases for 3 days. Okay, great. How does our body produce testosterone? Somebody mentioned in the morning it's the highest. Yes, our body produces testosterone like it does many things in a diurnal variation. So we should try to follow that diurnal variation. Topical does that very well. Pellets, you guys may have heard of pellets. It's a little procedure. They insert it in the upper hip area in subcu fat. It's an office procedure. They implant pellets, a scalpel, insert the pellet, and it delivers anywhere from 8 weeks to 4 months. It depends. Sometimes 5, 6 months in men. The problem with pellets is it is an office procedure. So you can have, it is an invasive technique. You can have side effects from the procedure, infection and stuff. The pellets do want to make their way out of the body a lot of times, protrude out. With active patients, if you're a bike rider, forget it. You got to not ride your bike for 7 weeks. I'm endurance mountain bike, or for 7 days. I'm endurance mountain bike racer. I would never be able to do that. Also, people that scar easy. My wife scars easy. She would never be able to do pellets. And again, pellets have a consistent level all day for months, but that's not how our body produces testosterone. Our body produces it in a diurnal variation. So I'm still a big fan of topical testosterone. Okay, dosing testosterone for women. So topical 2 to 10 milligrams daily, inner thigh, if the women aren't comfortable using it vaginally, but I'm a big believer for the reasons I said before to use it vaginally. Sublingual, same thing, because you're bypassing first pass, so it's still 2 to 10 milligrams a day. Short half-life injections, 5 to 10 milligrams twice weekly. I mentioned the peaks and valleys. Pellets, 50 to 150 milligrams every 5 to 12 weeks. Another problem with pellets is you don't know, especially when you put it in the first time, you don't know what dose you're going to need. So you check them 4 weeks later. And if it's too little, you have to give them a cream to supplement anyway. And if it's too much, they have oily skin and acne for 8 to 12 more weeks. So that's another reason why I don't like pellets, is because you can't titrate the dose. And there is no FDA approved product of testosterone for women. I was just working with a woman now that just texted me what a doctor prescribed for her, and a doctor prescribed androgel for her, which is the male dose of testosterone, and wants her to use a little bit of that. Well, the problem with that, a little bit, how much is a little bit? It's made for a man. It's a concentration made for a man. So it's really easy for the woman to overdose. So at a combine pharmacy, we make a specific dose for a woman. So, side effects of testosterone. Oily skin and acne is usually the first thing you would see if it's overdosed. That's reversible on decreasing the dose. Hematochromatosis, let's talk about that. Erythrocytosis, hematochromatosis. Hematochromatosis. So does testosterone cause hemochromatosis? Anybody? Polycythemia, does it cause polycythemia? Okay, so does testosterone raise our H&H? Sure, it does. I mean, that's one of the reasons it helps us to increase exercise capacity, okay? So, but let's talk about that. Now for men, usually with women in lower doses and they have, low iron anyway, this is not usually an issue. I talk about it because you can't talk about testosterone and not hear about this, okay? So does it raise H&H? Absolutely. So I dealt with a patient this week where his hematocrit was like 50.5 or something. And I was talking to his wife about it. And the endocrinologist was freaked out about it, wanted him to give blood, wanted to do all these tests about this. And I said, look at the normals of those labs. And I don't remember the exact normal, but he was 4% over normal. So think about that. This guy is feeling great. He's got increased exercise capacity because he has more iron partly. And we want him to go give blood because his H&H is 4% higher than normal, okay? Has anybody, crazy. And then they give blood, then they feel like crap for 10 days. But let's think about it this way. Has anybody ever checked an H&H on somebody that lives in Breckenridge, Colorado? Or at altitude? What happens to patients at altitude? They might have hematocrits of 51, right? They have to. They have decreased oxygen in the air. So in order to increase oxygen carrying capability, they increase their iron levels, right? Do we go tell them to give blood? Do we tell them they're going to have a heart attack? So it's not it's not erythrocytemia, it's not polycythemia. And I have a great video on our YouTube channel. If anybody wants me to share it with you on that doctor who's an expert on hormones. He goes into this specifically and he talks about the science of it. I just want us to think rationally about it. Now, here's another thing too. If a guy's hematocrit is 59, then that's a whole different issue, right? And usually one of the problems is that testosterone in therapeutic doses gets confused with what bodybuilders do. And if one is good, then 100 is better. And they use a lot of other things too, like Anavar and D-ball, Winstrol, all these other things. Can't even compare them. We are talking about therapeutic doses of testosterone that our body makes up. Other side effects, deep voice. If you use a female dose, you don't get a deep voice. Big muscles, same thing. Increased aggression, same thing. So this is one that I get all the time. Let's talk about this to somebody yesterday, I believe. clitoral megally. Will testosterone, especially applied vaginally, enlarge the clitoris? Yes, it will. This is what I find interesting. I was at a conference once and we were talking about this, and the gal was actually, she was actually talking, you know, very pro about hormones for women and testosterone for women, but she's saying be careful with the dose because you have to worry about clitoral megaly. And then she started talking about the clinical diagnosis of what clitoral megaly is. And it was something like this: 10 millimeters is considered a clinical diagnosis of clitoral megaly. I just had to ask the question. And I know I'm going to sound really smart aleck here, but again, I want us to think rational, okay? I want to know what the diagnosis is. If testosterone helps to increase penis size, what's a diagnosis of too big a penis? I mean, seriously, what's that? And you know, obviously the clitoris is analogous to the penis, right? And the clitoris does help for sexual function, definitely. So if you want women to have better sex, they will have plenty of testosterone and their clitoris might be enlarged. Their whole vaginal tissue will get better, okay? That's not a problem. Why is it a problem? I don't think it's a problem, especially if you think about, does it cause a problem for the female? Is it a problem for her? Is it a problem for her partner? Okay, then no. Now I get it. You can do some research on this and you will see these women out there that typically have abused anabolic steroids and they're bodybuilding type women and they look like a man, and that's not how we're supposed to look, and that's not how we're supposed to dose women. And all the power to them. If they want to do that, that's fine. But you'll see that their clitoris is like 2 or 3 inches long or something like that. That might be a problem, but that's not what we're looking at here. We are looking at, you know, therapeutic levels that women just aren't producing anymore. So what about depression? So let's think about some traditional treatments for depression. SSRIs, decreased libido, decreased ability to orgasm, erectile dysfunction. Remember, the penis is analogous to the clitoris, and weight gain. So women that are depressed come to us and we give them something that does this. This is straight out of the package insert from SSRIs. Is this going to make anybody really much happier in the long run? Seriously. And a lot of times they already have this decreased libido, decreased inability to orgasm, erectile dysfunction, because they have that. Those things can be caused by low hormones already. But what do? They get depression, and instead of checking their testosterone, checking their and optimizing their thyroid levels, we give them a medication that can cause more problems. This one, I tell you what, venlafaxine for hot flashes. When women have hot flashes, what do they lack? Interactive portion of the class here. What do they lack? Estrogen. They don't lack Effexor? They don't lack venlafaxine? No, they don't. So let's fix the problem, not just treat the symptom. And just think about, if anybody has had a patient try to get off venlafaxine, not that I've ever tried to get off crack, but it's like getting off crack. I mean, seriously, you've got to titrate it so long and so slow. It's horrible, horrible. So how many times have we seen a patient and their cycles start becoming irregular, or they had an oophorectomy and now all of a sudden they're depressed? Oh, well, you must lack Zoloft, so we're going to give you Zoloft, right? Well, think about it. Let's be rational. What did they just lose? They lost their hormones. And it's not just estrogen. We typically think women, estrogen. But let's face it, women make progesterone, women make testosterone. You got to look at the whole hormone picture. Testosterone is a mood elevating hormone, period. It increases dopamine and serotonin transport. I didn't include the references here. I didn't include any bibliographies. I can get some for you if you would like. But seriously, Google testosterone for depression. You will get a laundry list of stuff from PubMed. This one I have a big passion for. First of all, so traditional bone density treatments. Let's look at these. Biphosphonates, indicated. I'm going to go into. I'm going to look at the commonalities of all these first. Biphosphonates, indication postmenopause. Forteo, indication postmenopause. Prolia, postmenopause. What do all postmenopausal women have in common? What do they lack? They don't lack these drugs. They lack hormones. These are all FDA approved postmenopausal for women. That's what their indication is. So What do they lack? They don't lack these drugs. They lack a hormone. Think about that. So, and biphosphonates, it increases T-score, but does it make stronger bone? Well, osteonecrosis, package insert causes osteonecrosis. If you don't believe me, just look at a dental intake form when you go to a dentist, and they will ask, are you taking these drugs? Actonel, Fosamax, are you taking them? And if you are taking them, they refuse to pull your teeth. Because why? Because they were finding out that these women that were taking these drugs, when they would pull their teeth, they would shatter their jaw. This is public knowledge. Look it up yourself. So because of the way it works on osteoclast function, osteoclast breaks down bone. It doesn't build new bone. Osteoblasts build new bone. The biphosphonates don't build new bone. Guess what builds new bone? Testosterone, anabolic. Let's look at Forteo. The same thing. Different mechanism. It regulates metabolism of bone via parathyroid hormone. This is what I found interesting about this. This is in the package insert. You can look it up yourself. Only proven in postmenopausal women who took calcium and vitamin D daily. Does that sound like a very good random controlled study? Was it the drug or was it the calcium and vitamin D that helped their bones? I don't know. These are questions we have to ask. That's just a rational question. This is what I find interesting. Now remember, Prolia works different than the biphosphonates, but it also causes osteonecrosis. But look at this. Forteo, treatment for osteonecrosis, because it works differently in the parathyroid hormone. So how many women go on biphosphonates or Prolia, they get osteonecrosis, and we say, Mrs. Jones, I'm so sorry you got osteonecrosis. We want to make sure you keep your bones strong, but we can give you Forteo. But remember, what do all these women lack? Postmenopause, postmenopause, postmenopause. They lack hormones. Just think rationally here. So I have an ongoing challenge, and I challenge anybody in this room to please help me out. If anybody, any scientist, any doctor, any healthcare professional can find a better drug for bone density and testosterone, I'm all over it. I would love to know. I've got an ongoing YouTube video that has been went viral talking about this subject. So we learn in pharmacy school. What do we learn? We learn in pharmacy school. We learn that estrogens help to increase bone density, or it's good for osteoporosis, to prevent osteoporosis. Estrogen does decrease osteoblast or osteoclast function. It doesn't build new bone. It does not. So it will, at best, it will make your bones go like this. It will not increase your bone density. So how do we know these things? Do you guys know that testosterone is approved for men for osteoporosis? Did you guys know that? Right. Okay. So true story here. I'm talking to an orthopedic surgeon who has 40 years experience. And I was talking to him about bone density and testosterone. And he said, well, I understand how it could work for men because it's FDA approved for men. So it must work. If the FDA approved it, it must work for men. But he says, but I don't understand how it would work for women. Seriously. And I get it. We say that in healthcare because we are so used to letting the FDA and boards of pharmacy tell us what should be approved and what should be prescribed. We don't use our knowledge anymore and think rationally what we learned in school. But let's face it, I learned in Anatomy Physiology 101 that testosterone is an anabolic hormone, period. And that means anabolic to bone, okay? So why would it work any different in women than it would men? I mean, seriously, let's think rationally about it. So there are studies on testosterone for women, obviously, but there's a lot more of them for men because there's an FDA approved product for it. But let's just extrapolate. Why wouldn't it work for women? So when it comes to osteoporosis treatments, maybe it is testosterone. But the reason I bring this up is because I want to answer the question about, how long should somebody be on hormones? So if we were treating somebody for osteoporosis, how long would they be on something for osteoporosis? There you go. I mean, and here's what I would say. Well, I mean, you can stop your testosterone if you want your bones to get weaker and you want to decrease your libido and you want to have increased risk of cardiovascular incidents and you want to have depression. Sure, you can stop it. And then we could give you all kinds of fancy drugs for that. Or you can stay on testosterone, stay healthy. I want to just hit this really quick. the NICS test versus DEXA scan, you guys might be familiar with it. One of the problems with the DEXA scan is it takes, at least a year before you can see an improvement in DEXA scan. The NICS test will show how much basically you are metabolizing bone and actually urinating bone out. It's a urine test. So it's a lot quicker. You can do it you can tell what's happening with the bone within 90 days. And I will tell you, I've seen people increase their DEXA scan by 2 points just by using testosterone. So fix problems, don't treat symptoms. And these are some testosterone, some not, but just, think about the women we see in our office: hot flashes, vaginal dryness, decreased libido, weight gain, depression, osteoporosis, diabetes, hypertension, painful intercourse, chronic UTI, urinary incontinence, migraines, and irregular cycles. All those can be hormone problems. It's very, very important to fix the problem. Don't just treat symptoms. Think about how many drugs, if we just treat the symptoms, this person would be on. Whereas we balance our hormones, maybe just one. Okay, some case studies. Anybody have questions before we go into case studies? Yes, ma'am. Great question. I'm going to repeat it for the recording. If unopposed estrogen gives you cancer, does unopposed testosterone give you cancer? So unopposed estrogen, first of all, I don't think should ever be prescribed long-term. One of the things is that we learned about unopposed estrogen. I could do 8 hours on this subject, but we learned about unopposed estrogen because the first hormone that was ever prescribed for women was Premarin back in 1947. And we realized 10 years post, they were having an increased risk of uterine cancer. So then we said, well, we know that progesterone decreases the proliferation of uterine tissue. Let's mimic progesterone, and we come up with Provera. So, but now we say unopposed estrogen, they don't need opposed estrogen they only need progesterone if they have a uterus. Okay. So again, thinking rationally, is progesterone like a magic hormone? Does it only work in the uterine tissue? No, it works in the brain, it works in the bone, it works in the skin. So, and progesterone and Provera are not created equal. Let's think about what progesterone means. Progestation, okay? What do we use Provera for? There we go. We use it for birth control. So they're not created equally. In pharmacy school, I learned that they were the same, but that's how different they are. Usually when I say that, the bingo light goes on. They're like, wow, I thought Provera and progesterone were the same. No, they're not. So I personally don't believe any woman that's on systemic long-term estrogen therapy should not be without progesterone, whether they have a uterus or not. Progesterone is so important when it comes to proliferation of uterine tissue, proliferation of breast tissue, all the other things that estrogen increases proliferation of uterine tissue and breast tissue. Progesterone decreases that proliferation. Very important fact. Testosterone. Testosterone does not increase proliferation of uterine tissue in itself. No.
Online, please.
Online. Question online.
It says, isn't testosterone associated with DVT?
Testosterone associated with DVT. So testosterone is not associated with DVT. Testosterone does not increase clotting risk. I kind of hit into that a little bit with the cardiovascular thing. Let's just think rationally. If testosterone did cause DVTs, then 19-year-old men would be getting DVTs all the time, and they don't. But testosterone does not cause DVTs. And I have a great video that I can share with you. If you guys email me at the end, I'll give you my email with the clotting risk and testosterone. All right, let's get into some case studies. 49-year-old, this is just so common. 49-year-old, okay, that's a bingo light. Don't think about fibromyalgia. Think about the cycles becoming more irregular. It's a hormone issue, right? Well, it never started until my cycles stopped, until my cycles became irregular. And we want to, give some fancy drug. Hair thinning, depression started, she had a lack of citalopram. So we gave her citalopram. Recent diagnosis of high cholesterol, started atorvastatin. What are some side effects of atorvastatin? Muscle pain. Okay. She already, right? Hair loss. Yeah. Decreased testosterone levels, muscle pain, liver problems, obviously. Feeling aches and pains, especially around her neck and shoulders, taking hydrocodone and gabapentin. So check hormones. Patient is currently taking levothyroxine. I'm going to talk a little bit about, I'm going to focus on the testosterone. Testosterone symptoms mimic each other. Decrease all are low thyroid symptoms and low testosterone symptoms. So you really have to check them both. But here's what's important is her testosterone level, important for this discussion. Testosterone level is normal, on the low end of normal when it comes to total. But if you look at her free level, she's got a lot of bound testosterone. So her free level is definitely, talk about total versus free testosterone. When it comes to thyroid, think about TSH being the gold standard, but also the reason I say this is because we just have to really talk about it. When we monitor testosterone levels, if anybody's familiar with that, when we measure testosterone levels in men, most of you are probably familiar with that, what do we check? We check what? This is not a trick question. What do we monitor? We check their testosterone. We don't typically, in older men, check their LH and FSH, do we? So why do we, FSH and LH are pituitary hormones, so is TSH. So why do we check TSH as a gold standard? Just something to think about, rationally think about. So treatment, give the woman 2 milligrams topical vaginal testosterone, add some T3 to it, because remember her DHEA, think about DHEA, think about progesterone. I'm going to focus on testosterone for this presentation. 8 weeks later, her free testosterone is up to 5.1, which is above normal. Free T3 up, free T4, TSH down. No signs of oily skin or acne. So what was this? So let's think about how to interpret those levels and treat patients, not lab levels. What was this patient's testosterone level when she was 25? It was probably a lot higher than this maybe. We don't know. We don't have a baseline. But treat patients, not lab levels. And then know when the time of the dose is, what the most important part. Feels much better, increased libido, cholesterol is lower, pain levels are decreased, losing weight, more energy. So what can we do? Possibly stop atorvastatin. It's definitely not helping her pain and fatigue. Stops citalopram, which can cause sexual dysfunction. Treat problems, not symptoms. Know how to interpret the labs. Vaginal atrophy. No better drug for vaginal atrophy. Any questions on that case study at all? Any questions online? So we see this a lot also. How many patients do you see in their 50s that start getting chronic UTIs? And what do we give them? Well, I don't know. You never need a nitrofurantoin for the first 50 years of your life, Mrs. Jones, but you need nitrofurantoin now. What do they lack? Hormones. I mean, period. That's what they lack. They lack hormones. So, and also when it comes to urinary incontinence, and this is what I tell women when they start hormones. Usually with the vaginal symptoms, we'll see vaginal atrophy in her late 40s or early 50s. And painful intercourse. And I will go into, she'll say, well, how long am I going to have to use this? Usually for just that set of vaginal cream to start with. And really the reason why is because it's much easier for me to talk a traditional provider into prescribing estrogen cream first, rather than just going to testosterone. Because right away, if I say, well, this woman needs testosterone vaginally, a traditional healthcare provider that doesn't know about hormones, it'll scare them right away. And I just lost all my credibility. So I do know that S-Trial vaginal cream will work. It will work for sure for chronic UTIs, for urinary incontinence, and for vaginal dryness. I know that. And I know that we're all trained. Our schools teach us that kind of stuff in our training. So I know that one's an easy way to fix their problem. So I would really normally recommend just S-Trial, but later on, I usually get to the topic of testosterone. But look at some of these things: vaginal dryness, causing painful intercourse and marital issues, total hysterectomy at 49 years old due to uterine fibroids. So we talked about unopposed estrogen, uterine fibroids. What causes uterine fibroids? Estrogen makes our proliferation of uterine tissue, right? It causes proliferation of uterine tissue. Progesterone decreases that proliferation. Not Provera, but progesterone does. It's anatomy physiology 101. Look it up. So when women get uterine fibroids, a lot of times, especially later on in life, or if they've been pregnant, after pregnancy, it's from too much estrogen and not enough progesterone. You usually give them a little bit of progesterone, and it will decrease the proliferation of uterine tissue, the overgrowth of it, and uterine fibroids go away. She might not need a hysterectomy. And then here's another thing. We put them on HRT, they feel better, and then, but because of the WHI study, we say that, well, you can't be on HRT over 5 years, it's too dangerous. So, and that is just pure ignorance. You look at the WHI study from 2002, the WHI study proved one thing: Premarin and Provera increased risk of cardiovascular accidents. Now, if you look at the treatment group versus the placebo group, the treatment group was 10 years older, significantly 10 years older. I mean, 65 versus 55. There's a big difference in cardiovascular events from a year-old anyway. So anyway, but all we can take away from progesterone are bad. Not necessarily bad, but in that study, it was. It doesn't say anything about estradiol, doesn't say anything about progesterone, created totally differently. Remember, Premarin, does anybody know what Premarin stands for? Pregnant Mary's urine. You know, this is honest to gosh truth. As pharmacists, we should all know that. And they used to teach us that in pharmacy school. They don't teach the pharmacists that now. And I think there's only one reason why. Really? Pregnant Mary's urine? We're going to give women horse pee? I mean, seriously. I think that's why they don't teach them that, because a lot of the new doctors coming out, they don't know either. But it is. It's pregnant Mary's urine. There's at least 19 different estrogens in there. And when it's isolated from urine from different horses, we don't know what all's in there. We only know what we know to look. And it's standardized by estradiol ratios. They standardize by estradiol ratio, but one batch varies from another batch. That's why there's never going to be a generic Premarin, because you can't copy it. You don't even know what's in it. You can't copy it. Beautiful drug for wife there. But we took them off HRT because it was bad for 5 years. But then all these symptoms come back. So what would we do when she goes off HRT and then she has UTIs and she has urinary incontinence drug? Because it's okay to take oxybutylene and nitropranatoin for more than 5 years, right? And of course, there's a lot of studies coming out about nitropranatoin and the long-term side effects, not even its antibiotic type side effects. But I think anytime you're taking chronic antibiotic problem, I mean, we have a healthy immune system for a reason. So there's other issues probably going on if you're on chronic antibiotics. This is what really, really infuriates me. When you talk to women about this, when it really infuriates them. So went to a traditional doctor, family practice doctor, and because her sex was painful, he prescribed lidocaine gel. I mean, seriously. I mean, really. And he did that to at least 2 different patients we know of. They contacted us, and we were able to get her into somebody to prescribe, to balance her, to prescribe vaginal estrogen, actually. But I think this one specifically got referred to urology, which urology knew about that. But remember, painful intercourse is the cause of some other line issue. Follow up in 8 weeks. This is the thing. There is no reason for women to have vaginal dryness. There is none. And if all they want is trial topical estrogen, you know, most oncologists will even recognize breast cancer that's even safe in women. So no reason that women have to live with that. There's none whatsoever. So UTIs clear up to 4 weeks. We can stop the nitropranatoin. How long should you continue the estradiol cream? I mean, she doesn't want her vaginal dryness to come back and her UTIs to come back and her urinary incontinence to come back. Then we tell women that all the time. You're not going to magically start making your own hormones again. You're 60 years old or whatever. We have 90-year-old women on estradiol vaginal cream. A wonderful story I had one time on that specific drug is she called and she wanted to talk to me. And I'm like, oh, okay. And I estrogen vaginal cream from us. And I'm like, what? Save your life over estradiol vaginal cream? How easy is that, right? And she said, not be able to drive across town without wetting myself, and now I can drive again and be independent. I mean, think about that. She found a urologist that was willing to help fix the problem. She couldn't take a reason And we actually fixed the problem. So any questions so far? Yes, you first.
So if you're going to prescribe testosterone, where does that come from? I mean, is that a synthetic? Or
No,
where is that acquired?
Yeah, that's a great question. So pharmacists make testosterone in a specific dose for women. Basically, all forms that I talked about earlier, they make a specific dose for women. We prefer topical and vaginal testosterone.
That's not my question.
Okay.
What's the composition? Drug.
The
synthetic?
testosterone drug.
Yeah. What is?
The testosterone synthetic and that synthetic versus natural versus bioidentical. Is Premarin natural? Premarin is natural. Yes, it is. Premarin is natural. Is it natural to humans? No. Okay, synthetic. We always get this one. Is natural? No. Levothyroxine and liothyronine are synthesized in a laboratory. An amino acid, and T3 liothyronine has 3 iodines, T4 levothyroxine has 4 iodines. It's made in a laboratory, but it's bioidentical. It's bioidentical to what our bodies make up. Same thing with testosterone. Testosterone is normally isolated. Most sex hormones are normally isolated from either and then they synthesize it in a lab to get down to the testosterone. It's the same exact testosterone our bodies make. It's the same exact testosterone that Big Pharma uses, Androgel uses. They use the same companies that we source our testosterone from. So those chemicals come from the same places that big pharmaceuticals companies get their chemicals. Usually made from China or India, unfortunately. So does that answer your question? What's that?
Natural sources of plants.
Well, soy and testosterone,
Yeah.
soy, and it's testosterone. There's a synthesis process that goes on. Does that make sense? Okay.
I have a couple of one question. Isn't it FDA approved for women is one. And if it's not FDA approved and I'm prescribing it, then I think about liability. So that's and the other thought I had when you were, why don't I see my patients that I refer to endocrinology more, into treating with testosterone modalities? I know that's a lot, but
Right. No, those are all great questions. First of all, a lot of the patients that we see, they've been through the route system chronology and they weren't happy with their, so they find something that's alternative. When it comes to FDA approval of things, 50% of everything that we prescribe every day is not FDA approved. So have you ever prescribed furosemide for CHF? I'm not sure what kind of practitioner you are.
yeah, I'm primary care. Yes,
Primary
I
care.
have.
Furosemide is not FDA
Yeah,
approved.
and I do use a lot of off-label.
Exactly. We all do.
medication,
We all do.
but-
Patients would die if we didn't use it. Furosemide is not indicated for CHF, it's indicated for hypertension. We do it all the time. Codeine has never been FDA approved. I know we don't prescribe it much anymore, but not FDA approved does not mean it's not safe and effective. So 50%, like I said, 50% of all the stuff we use every day is from non-FDA approved things. Now, go ahead.
But why isn't the FDA more aggressive with testosterone studies in
Right.
women?
I'm glad you asked that. They've been, and I was super excited about some of them. And then for whatever reason, like second or third stage clinical trials, they get pulled. And I don't know why. I mean, I think what's weird, and I'm not here to that you see this quite often in sometimes women's health type issues. Like for instance, I mean, if the treatment of any kind of hormone related issue was cutting a man's balls off, would we accept that? We accept for women all the time. I'm serious. I'm not being politically correct, but I'm serious. No, yes.
if testosterone was used more effectively, then we wouldn't need all these other medications for osteoporosis.
You know
and
what?
All these
Why
hormones.
don't-
Just a thought, just.
Come here and take the microphone. You can do my for the last hour. Is I want you to be thinking about that kind of stuff. I mean, seriously. And our patients, we preach health and wellness, and we preach hormones. And we don't want, my wife and I are two pharmacists that don't believe in pharmaceuticals to treat long-term disease, period. Okay. I got 5 minutes, right? Okay. I think that's a great question, and I don't know the answer to that. I wish I did. Women have options, and they can. There's a non-traditional pharmacies. So as we wrap this up, I want to talk about this. I get you my slides too with some of those other case studies. I hit on most of the points, but there's a hierarchy of hormones. So I talk about sex hormones a lot, and that's what we usually replace. But remember, there's a hierarchy of hormones. It's adrenal hormones, and without adrenal glands, we will die, right? Right. Without our ovaries and our testes, we won't die. It'll suck, but we won't die. So insulin. This is a new one that I just added to my hierarchy of hormones. I used to have adrenal, thyroid, and sex hormones. But insulin. If people's insulin is a hormone, it's a hormone. It's a peptide hormone. Insulin is a hormone. So when a doctor says, be cautious when a doctor or any healthcare professional says, oh, well, you've got breast cancer history, you got to go off all your hormones. Insulin's a hormone. Thyroid's a hormone. Let's define what hormones are, okay? And that being said, when we get into the sex hormones, I just told you how estrogen, progesterone, and testosterone are different. So they're not all created equal. But insulin, if your insulin level is high and you're metabolically not healthy, a lot of things won't get better. So you got to fix that problem. Great news is testosterone helps to decrease visceral fat production, which can decrease insulin resistance. So very important. So sex hormones are down at the bottom. That doesn't mean they're not important, but all these other ones are too. And hormones are a piece of the puzzle. If you don't sleep, you don't eat right, you don't exercise, you're not going to live your optimal. I look at it like this. If you do the construction analogy with hormones, let's use testosterone, for instance. Let's say testosterone is analogous to the contractor that's building the house, okay? And we can use this with a bones or muscle analogy. Testosterone's a contractor. What you eat is the wood in a house. If you've got a good contractor, but you don't have the good structure for the wood in the house, you're not going to have a steady house. So these things are important also. Hormones can obviously help optimize these things. The most important one of these, it's not diet, it's not exercise. We will die without sleep before we'll die without food. Those are facts. And we do not have to exercise at all to live, but we do have to eat. So in this order, sleep, diet, exercise are the most important. Any question? Yes, sir.
If I can ask a personal question, what were your testosterone levels, and what do you take any testosterone?
You know, I prefer not to share after the last 3 years, I prefer not to share my personal medical history publicly. I think it's just something that we should keep personal. Is that okay? Okay. Yes, sir. Or yes, ma'am. I'm sorry.
Just a quick question. When you talk about the normal levels, for females, the one that you had the slide in the beginning. So is that what you go by? So let's say a patient comes in, you do the blood work. So are they usually within that normal range or less? So if it's less, yeah, I can see that they're low in testosterone. So then what's the goal? Because you kept referring to well, that's just a level. So then how do you titrate the testosterone? So now everything is based on patient symptoms. So but anyway, I was just wondering because, so if they come in, they have all the symptoms, but their testosterone level is normal.
I think that's great.
Then what do? You still think it's testosterone is low?
What's the goal? What is the goal? The goal is not.
That's what I mean. I mean,
right,
because that's why I was wondering, do you base it on the level or do you base it on symptoms?
Symptoms and history mostly. Remember, the goal is to make them feel better. Labs are just a tool to help along with that. What's that?
You don't have to do the lab.
You don't have to do the labs. You're right. you're right. Here's the problem with that. And we see this all the time is when you do the lab, you got to be ready to address that lab. So let's say you've got a guy feeling awesome and his level's like 1250, which is higher than normal, right? Well, when you do that lab and his level comes back 1250, and then somewhere down the road, he sees an ER doctor or he sees a endocrinologist for whatever reason, they are going to freak out and they're going to call you. So you got to be ready. You just got to be prepared to address that. You know, and I think we use labs as black and white, and they're just not. But look at, I mean, cholesterol is a good example. Well, 200, you're fine. 201, you need a statin. I mean, seriously, how ridiculous is that? Don't look at the other things that are going on. Don't at all. It's just like, that's what the standard says. You know.
I guess that's where it comes in, is because, you know, we're all practitioners and, you know, we have certain limitations in our licenses and all of that stuff. So at least if an ER doc calls me, hey, why did you put somebody on a statin at 201? There's some data to back us up. But if they call me because the testosterone was 1250, what am I going to say? Well, because the talk that I went to for an hour talked about it and says it's okay. So
Well,
I think that's a difficulty with this in this particular and I'm not saying it's not helpful, because I have seen patients, but to initiate this is probably one of the hardest part. And one of the reasons why I actually also came in today was to actually listen to this talk. And so I was really hoping to, like, you know, make it easier for practitioners that don't normally prescribe testosterone to be more comfortable. But then it's even just got more confusing. So
first of all,
anyway, so that's just my comment on it. I mean, I'm not saying it's not helpful. I
Right.
think there is a role for it, but for
Right.
people who are not used to practicing or prescribing it would be a good opportunity. So
first of all, if you work with healthcare professionals, a pharmacy specifically, I'm talking about us, we help you through that whole thing. And we can help you with dosing, and we can help you with monitoring and things like that. Now, here's another thing. Here's another trick that you could use. Okay, your testosterone came back 1250. All right, that's a little bit high. You just used it an hour ago. It should be high. You know what? I want you to come in 4 weeks, and I want you to not use your testosterone that morning. And then you check your testosterone, it's back down to baseline at 400. And then you're safe. It's like, okay, well, yeah, look, your testosterone level is normal. I mean, I know that's playing games, but that's the whole thing about lab testing. It's a small snapshot in time with any lab, you know, for that matter. So, and you know what? Balancing hormones, I'm not going to lie. I mean, it's all my wife and I do now. It's not easy. That's the whole point of why a lot of people don't do it. It's much easier to say, well, your cholesterol is 201. You've got a statin deficiency. Here, I'll give you a Lipitor 10 milligrams. It's much easier to do that. And speaking of big pharma is good at getting a lab, making it black and white, and then we prescribe something for it. But hormone balance, just like I talked about in this slide, it's important. You got to go over all these things. Yes, ma'am.
Can you give testosterone in pills?
Testosterone in pills. So testosterone is not absorbed very well orally. For women, you can do it in a higher dose. I'm not a fan.
So
I
for
would rather.
men, do you prescribe them a cream then?
What's that?
For a man that needs testosterone, do you prescribe them
I
a
love
cream?
testosterone as a cream for man.
What do you ask the pharmacy to compound for you for creams?
I like 200 milligrams per mil. Apply it underneath the scrotal area. Scrotal area, great thin skin, great blood flow, less risk of transfer than if it's on their upper arm and chest.
The same for women?
Well, women's 2 to 10 milligrams, way
2 to
less.
10 though.
And vaginal, yep.
So they don't need as much. And
Nope.
then for your 19-year-old analogy, it seems to me that the side effect that men have at age 19 is stupidity.
I'm sorry. I'm sorry. One more time.
The side effect that men have at age 19 of testosterone is stupidity.
Oh,
Or shooting up classrooms.
Well,
What's
I
the
mean,
average- what's the average age of
let-
a
let-
shooter?
I mean, let's face it. Let's just be honest about it. I mean, look at some of the things that men do that women don't, that put us at risk for death, whether it be jumping off cliffs, whether it be parachuting, whether it be jumping motorcycles, whether it be jumping mountain bikes, going down a hill, you know, at 50 miles an hour. Most women don't do that. Men do that because they have more testosterone.
So why would I want my women to do that?
Well, the thing is we give female doses. You don't get those men side effects.
Oh.
Yeah. And believe me, I have 2 kids that are 21 and 23. I know all about stupidity when they go through puberty. And I love my kids, and they're grown up to be great men. All right. I think we're out of time. Is that true?
It is, but
Okay.
well done.
Thank
Thank
you
you.
so much.
Good questions. Thank you.
Here is, if anybody, I thought I had a slide on here. Oh, I do have a slide on here. If anybody wants to write my email down, I think I have it here and my cell phone. If anybody wants to get a hold of me, please let me know.